Osteoporosis basically is a skeletal disorder. It's characterized by compromised bone strength, which leads a person to increased risk of fracture. And if you can see, basically the bones are more porous. I can't see the, yeah, so the bones are more porous as compared to the normal bones, and there is increased risk of fracture. The concept of osteoporosis becomes little easy from this diagram. If you see, there is an imbalance between bone formation and bone resorption. And to make the concept more clear, we can draw an analogy from something which we can understand very clearly, something like high blood pressure, which is a risk factor for stroke. Similarly, osteoporosis is a risk factor for various fractures, and these fractures are the fractures of the spine, the hip, and of the distal forearm. Worldwide, after the age of 50, 1 in 3 women, and in men, 1 in 5 men will suffer from osteoporosis, and every 3 seconds worldwide there is a osteoporotic fracture. It is estimated that almost 200 million people are suffering from osteoporosis, and the projected figure by 2050, there is increased incidence of hip fracture both in men and female, to such an extent that we need to gear up our health, the health system. The combined risk of having risk of osteoporotic fracture of the hip, forearm, and the vertebral fracture is almost equivalent to that of having cardiovascular disease. And majority of us are just worried about the cardiovascular disease, and we don't even have our screening done for bone health. So if you see the Indian fact sheet, it tells you something else as compared to the world. It tells us that the Indian patients are much more prone, they are much younger to the Western population. Our epidemic starts at the age of 50, whereas in the West it starts at the age of 70. And the incidence is much higher in male as compared to females also. The lifetime incidence in men is almost after the age of 50, is almost equivalent to that of having a risk of prostate cancer. And once you have hip fracture, there's increased incidence that 20% of the people will die within 4 months, and almost 30% die within a year. So now to the risk factors. So age and gender has been extensively covered. Now the ethnicity, Asian women and Caucasians, they are much prone to osteoporosis. Also, if there is a family history, there is more risk of osteoporosis. If there is prior history of bone fractures, cigarette has been covered extensively, but it's not only that, it's a reverse smoking, which majority of the Indian people do by tobacco chewing and pan masalas, which have not been mentioned in the literature. So these kind of meetings, at least we can discuss those things also and discuss with the patient that these are equally bad. Alcohol and certain diseases, chronic diseases like dementia, medications, and in majority of them, it's multiple risk factors. So the risk factors can also be divided into modifiable and non-modifiable. Like if the menopause is early, then perhaps you can modify it by giving hormone replacement therapy. If you take less calcium, you can replace that also. You can prevent falls, and there are so many other factors which are very important, risk factors for osteoporosis. So one of the risk factors is being lean and thin. So we did a study whether obesity is a risk factor in our setup, and to our surprise, there was no correlation between the BMD and the BMI. This was a postgraduate thesis at our hospital. What about the alcohol? Alcohol is not safe. It's, if you're consuming more than 3 units, and this is the definition of the units, it is toxic directly to the bones. And connecting the two talks, we did in fact, our group was the first one who did a pilot study in HIV patients to see whether they have a bone involvement or not, because it's a chronic disease. And we found that there is increased incidence of osteoporosis in HIV, and subsequently 60 patients were taken, and we found that close to 88% of the patients with HIV do suffer from some problem of the bone. And what about our health workers? This is the data from our hospital. Close to 90% of our people working in the hospital, doctors, paramedical staff, they have some problem, either osteopenia or osteoporosis. And multiple reasons could be found for that. So coming to drugs, I think conventionally everyone knows about that corticosteroids is the most commonest drug which may be associated with osteoporosis. However, one drug which all of us use is proton pump inhibitor. And this is the drug which I think the message should go very clearly that proton pump inhibitor has been associated in meta-analysis with increased risk of bone diseases. Vitamin D is a key player, and majority of us, they have a type 2 skin where vitamin D is not absorbed even if we are in the sun. And there are various sources which are available. I think all of us know that it's in two forms, D2 and D3. So globally, majority of the countries of the world are vitamin D deficient. And in India, various studies have been there, but out of 70 to almost 100% in various studies have shown that the Indian patients are vitamin D deficient. And various reasons which have been cited are basically, it could be related to our socio or regional regions, or because of the skin color which has been mentioned, or because we are living in metros, because we don't get direct sunlight. So what we require is bare 45 minutes of sun at a time between when we are working inside between 12 and 3, when majority of us are busy in our clinics. So, but that type of exposure is not required, and that's why we are all vitamin D deficient. So now, what are the clinical features of this? Basically, it's a silent disease, but certain patients, they have aches and pains, there is loss of height. Certain people have this deformity, but by the time they come, it's very late. And a few patients, they come with compression fractures, but by the time the fractures occurred, there's almost so much of disease has already occurred. But majority of people in our setup at least are picked up when there is a fracture. And vertebral fractures sometimes may have atypical presentations, especially in elderly. They may present with lack of sleep and depression. So this is an area which should be also looked into. So once we know the risk factors, how do we diagnose? It's important to diagnose because I believe that all of us know how to do with the simple diseases like getting the ECG done. But when it comes to bone health, I think majority of us are not even aware to what tests to do and what to do and whom to refer. So those are the things. So this is an 19 questionnaires. It takes only 1 minute, and they are by the International Osteoporosis Foundation. If the answer for majority of them is yes, it means you require some test for the bone. And for us, if we see all the doctors, majority of them would be yes. And this is the validification of the questionnaire which we did, and we have also converted this into Hindi. So the diagnosis of osteoporosis, it comes by something called DEXA scan, and the drugs available are of two types. They are classified into anti-resorptive and anabolic. I'll be just covering briefly few of them because, you know, as a family physician, you people should be aware of what are the drugs available. So the main group of drugs are bisphosphonates. They are the cornerstone of the treatment. And the story of bisphosphonates is something like the old classical movie, the good, the bad, the ugly. The good thing about them is that they increase the bone density and they decrease the risk of fracture by almost 40% or so. The main disadvantage is that the oral bisphosphonates, they need to be taken in such a way that early morning you have to take it with water, and then the patient needs to be walking for at least half an hour. The other bad thing about bisphosphonates is it's going to be protecting for the bone, but however, their case reports that there are atypical fractures of femur associated with it. And the ugly thing is the osteonecrosis of the jaw. So any patient on bisphosphonates should be counseled for the dental procedures. And the fact about the bisphosphonate is that once you don't take it, the protection upon the bone goes off. So that if you take it way less, the protection is almost not there. So to cover up, we have once yearly infusion of zolandric acid, which is available, which is extensively used in the hospital setting. The patient needs to be there only for half an hour in the hospital, and the thing is done for a year. So there are many reasons how we choose it, and I think this can be covered from question answer session. So we did an audit because this medicine is available both in generic and the innovator. The innovator is almost 5 times expensive as compared to generics. Generics are very cheap in India. And we presented this data in the EULAR conference in 2013, which was taken as a poster tour. And we found that almost the side effects of the two are almost similar. The other group of drug which is important, we need to recapitulate a little bit about the calcium metabolism. The teriparatide is a drug, and if we give it continuous, it is catabolic, but if we use it once daily in high doses, it is anabolic, and that is what is used when we give teriparatide. However, it has to be given injectable daily for 6 months to 2 years, and it is a costly affair. The new drug which we published this year in January this year, that there is a monoclonal antibody called Denzumab, which is available, and this is a study which we did in the postmenopausal woman. This is basically a randomized controlled trial, and as expected, there was an increase in the bone density close to 3% as compared to the placebo. So you must have realized that osteoporosis is basically a multidisciplinary field, and we did publish this paper which was there, in which since osteoporosis crosses many specialties and requires the help of gynecologists, the physicians, the orthopedics, the physiotherapists. So this is the importance, and I think there the role comes of general practice also. Obviously, vitamin D and calcium are very important, but we should basically have that from our diet, and role of exercise, I think, can be covered in the question answers. And the diet should be mainly from the kitchen diet rather than it coming from the tablets. And our Indian cereals are very rich in calcium, especially the ragi, the pulses, the dairy products which are quite rich in calcium, and even the fruits, green leafy vegetables, the nuts, meat and fish, and even the spices. So Indian, if you see the food, and if you can calculate by using a calcium calculator which is easily available, you don't require calcium supplements. So to conclude, in women, there is a rapid loss of bone, especially when there is a menopause, and that increases the risk of fractures, and there's a decrease in the bone health. But we should also remember that it involves men also. And once you have a hip fracture, there's increased risk of DVT and pulmonary embolism, and there is increased risk of mortality and morbidity. And the maximum bone health is achieved during, when we are young. So we could encourage the children to play outside in open rather than they're just, there on studying table. DEXA is a simple way to diagnose the osteoporosis. The best sources for taking calcium is the dairy sources. We are a vitamin D deficient nation, and the food needs to be fortified, especially it coming from the government. And two diseases, if you have to be ruled out in osteoporosis, multiple myeloma and asymptomatic celiac disease. This is the book which we have written about bone health, should be available in the next 2 weeks or so from Elsevier's, and I'm ready to take any questions from the audience. Thank you.